it over now to our presenter and one of our skilled ENT surgeons, Dr. Carly Schrage.
All right. Hi, everyone. Okay, can everyone hear me okay? Maybe Chelsea, you can let me know. Okay, great. Can you hear me okay? All right. Okay, so everybody, hi, my name is Carly Schrage. I am a ear, nose, and throat physician, and I specialize in sleep surgery. I have a particular interest in sleep surgery, so that's what we're going to be talking about today, is obstructive sleep apnea and what the treatments are, not just surgical treatments, but other treatments as well. Okay. So we're going to start by discussing what is obstructive sleep apnea, who has it, what are the symptoms and the health consequences, and the causes. And then we're going to spend most of our time on the last section discussing treatments. So sleep disordered breathing is the overarching category, the larger category that obstructive sleep apnea falls under. But it also includes snoring and central sleep apnea. So we're going to talk about the differences between these things. Snoring can be a sign of obstructive sleep apnea, but it can also occur on its own. So it doesn't necessarily mean you have apneas. It's not dangerous if the snoring just occurs in isolation. But improving breathing through the nose can often help snoring. So a lot of the treatments, if it's just a snoring problem, focus on improving airflow through the nose. And that's what this gentleman is doing. He's putting a little breathe right strip on his nose to help open it up a little bit more. Okay, and then there's sleep apnea. Sleep apnea can come in different forms. It can be central, it can be obstructive, or it can be mixed where they occur together. The obstructive sleep apnea is the one most people think about when they think of sleep apnea, but we can't forget the central type because that's important as well. And it's often treated a little differently. Okay, so central sleep apnea. That is when your brain doesn't send the signal to your body to breathe. So no obstruction is occurring, there's no collapse necessarily. It's just that your breathing just takes a pause. And that cannot be fixed by removing tonsils or doing any surgery in the throat because it's not a problem with obstruction. It's a problem, it's a neurologic disorder essentially that causes you to have these pauses in breathing. It's not as common as obstructive sleep apnea, but we do see it frequently. Obstructive sleep apnea is when your body is trying to breathe, but it can't get the air because there's some sort of obstruction occurring. It's usually in the throat somewhere, kind of the neck area, throat, or the way in the back of the nose. And you're trying to take a breath and there's a collapse and obstruction so you can't breathe. And then your oxygen drops as a result. And this is happening repeatedly throughout the night. So you can see that picture there. Air is trying to go through the nose and through the mouth, but it's running into blockages, and that's blockages of the soft palate, blockages of the tongue, and the air can't get through. Okay, so, I didn't mention the obstructive and the central can also occur together. So you can get both at the same time, maybe 10% central, the rest of it obstructive. There can be a mixed form as well. Okay, and then who has obstructive sleep apnea? It's most common in 30 to 60-year-olds, and it's a little more common in men than women, so you can see the numbers there. 9 to 24% of men and 4 to 9% of women, depending on the study that you look at, have obstructive sleep apnea. It is 2 to 3 times more frequent if you're over 65 than if you're 30 to 64. So it does tend to get more common as we get older. And it's 2 to 3 times more common in men than women. But the survival rates are actually lower in females. They have more severe issues when they have obstructive sleep apnea. And some of that we think is because of delay in diagnosis. People think of it as more of a male problem, so they're not they're not searching for it in females as much, and they get missed. So it's very important to consider this in females as well. African Americans and Chinese are at increased risk. This has to do with the differences in anatomy and shape of the neck and facial structures. And so it's not just about weight, it's not just about size, it's also about how people are shaped, and these groups tend to are at increased risk. So what are the symptoms? We talked about the symptom of snoring. You can also have witnessed apneas. So apneas are when you stop your breathing. So your bed partner can say, oh, they stop their, you stop your breathing at night all night long. I have to nudge you to get you to breathe again. I can hear things just pause. You can also have restless sleep or waking up gasping. Also, feel sleepy or tired during the day. You just feel like you're never well rested. You're always tired. If you fall asleep more easily during the day, maybe even fall asleep more easily when you're driving. Also, morning headaches and dizziness. Those can be signs of obstructive sleep apnea as well. And you really do not need all of these things. Some people have very few symptoms, even though they have severe sleep apnea. And it's still important to treat it if that's the case. But these are a lot of things that tend to be common. So what are the health consequences? Why do we care about obstructive sleep apnea? So first of all, it often impairs your quality of life. So if you often are just not feeling well, you're feeling tired. But apart from that, it also increases the risk of death from heart attack and stroke. So you are more likely to die sooner if you have obstructive sleep apnea. And you're also 2 to 7 times increased risk of getting in a car crash. And that could be because people are falling asleep at the wheel. But even apart from falling asleep, you might just not be as quick to react to things, delayed reaction time. So you're much increased risk of car crashes, which is really important. These risks are frequently reversed if it's treated. So don't despair. If we can treat it successfully, a lot of these things go back down to normal risk. So what are the causes of obstructive sleep apnea? Well, they fall into 2 major categories. And here we're really talking about the obstructive form of sleep apnea. For the rest of the talk, we're not talking about central because that's pretty different. But with obstructive, the main causes are weight and anatomic factors. So for weight, people who have higher BMIs, who have larger neck circumferences, are at much increased risk of obstructive sleep apnea. But you may notice that some people are very large and they don't have sleep apnea, or some people are very thin and they do. So this is not by any means the only factor, but it is an important one. And the higher your BMI goes, the more common it is to have obstructive sleep apnea. Okay, and then there are anatomic causes, purely apart from weight. Now, small jaw is one of them. You can see in this x-ray, when you're looking at this patient from the side, we're looking at how their lower jaw is small and it's pushed back. And when it's pushed back, your tongue gets pushed back and there's less space behind the tongue for breathing to occur. So small jaws, small mandibles, give you an increased risk of having obstructive sleep apnea. And this is one of the ways it can run in families. Certainly if being overweight tends to run in your family, you'll be at increased risk, but also small jaws. If a family tends to have smaller jaws, you might notice that a lot of the members of that family end up having obstructive sleep apnea. Large tonsils and adenoids, particularly in kids, cause obstructive sleep apnea. Now, for those of you who don't look in mouths every day, you might be confused at what you're seeing here, but this is a child's mouth, and we're seeing really large tonsils, which are taking up pretty much the whole back of the throat, and they're touching each other in the center. The tongue is at the bottom of the picture, and you can see some teeth there too. But essentially, those are really large tonsils, and when they get really big, they can cause blockage and cause sleep apnea. And in kids, most of the time, if you remove the tonsils and the adenoids, which are a little bit behind and up from the tonsils, then you can cure obstructive sleep apnea. So usually in kids, that's all that's required. unless they have some sort of syndrome or like Down syndrome. But in adults, it often is not the only factor. Another issue is a long, soft palate and large tongue. So click forward for me on this one. So if you look in the back of people's mouths, you'll see different things. Sometimes it's really easy to see the uvula, which is that part that hangs down in the middle and the back. And sometimes you can't see it at all. And this has to do with how much room there is in the back of someone's throat, how long their soft palate is, how large their tongue is. And we classify this into different classes. So there's class 1 where you can see everything easily, and class 4 where all you can see is the hard palate. And so if you're over at class 4, you're at much increased risk for having obstructive sleep apnea. Okay, another cause is poor neuromuscular tone while you're sleeping. So that means that everything, all the muscles in the throat become more floppy and collapse easier when you're sleeping. Some people just have a genetic predisposition. They just tend to do that. Their muscles get really relaxed when they sleep and they tend to have more blockage. Down syndrome will also have that problem, muscular dystrophy, hyperthyroidism, something called polymyositis, which is an inflammation of the muscles and has an autoimmune component, Parkinson's disease. These types of neurologic disorders sometimes cause things to be a little bit more collapsible while you're sleeping, and that will increase your chance of sleep apnea. Okay, now we're going to move to treatments. We're going to be focusing on treatments for the remainder of the talk. I think this is what most people are most interested in. So we're going to start with lifestyle treatments. We don't want to minimize this. Weight loss is a big one for people. But it's not the only factor. Like I said, some people are very thin and they can still have sleep apnea, but a lot of people can cure their obstructive sleep apnea with weight loss. So that's an important thing to note. Exercise, so it's related, but it's also a little bit different. Exercise helps with sleep apnea even if you're not losing weight. And the thought is that when you do a lot of heavy breathing, you're toning some of the muscles in your throat and you're causing them to be stronger and less collapsible. So even if you're not losing weight, don't get discouraged. The exercise is still likely helping. Decreased alcohol consumption. So when you drink alcohol, things are also more likely to be floppy and collapse. So a lot of alcohol before bed will increase sleep apnea. And a lot of people note this anecdotally, say, oh, whenever I drink, I tend to snore more. Sleeping on your side sometimes can cure sleep apnea. Some people only have it on their back. And elevating the head of the bed, same thing. It can really help the numbers and help reduce sleep apnea. So a lot of these things are really useful tools and can be adjuncts to other things that we do. There are devices that help encourage you to stay on your side, or you can use pillows around you at night, or wedge pillows to elevate your head. So these can, we don't want to minimize these. They can be really helpful in at least decreasing the sleep apnea, if not curing it. Dental appliance. So there are dental appliances that can be used to treat sleep apnea. They typically are more effective in people who have mild sleep apnea, and often for people who cannot tolerate the CPAP machine. And we'll talk more about CPAP here in a minute and what that is. There are multiple types of dental appliances. Some are meant to move your lower jaw forward. We talked a little bit about how a smaller lower jaw or a lower jaw that's sitting back can cause obstruction. Some are meant to pull your tongue forward or lift your palate, but regardless, they tend to be more successful in people with mild sleep apnea. Reasons why you might not be able to do a dental appliance: if you don't have very many teeth in your mouth, then there's not as many teeth for the dental appliance to fit to, and it might not be an option. If you have limited jaw motion, so you're really not able to even move your jaw forward much, then it might not work well for you. Temporal mandibular joint, or TMJ problems, can be an issue and can worsen with oral appliances. That's a big issue for people. Or if you have a lot of bruxism, we call it, or clenching and grinding of your teeth, that you may end up breaking the oral appliance regularly, and it might not be a good option. The results of a dental appliance, much more successful for the mild cases, like I said, and not so much for the severe cases. Every once in a while, they can worsen sleep apnea or at least do nothing to improve it. So I really encourage all patients after they get a dental appliance to get another sleep study and check how well it's working, because it may not be working, or it may be worsening things. So there's no way to know that for sure. It's not advancing for me. Oh, there we go. Okay. All right, so complications of dental appliances, it can cause TMJ issues, myofascial pain, and malocclusion, which is where your teeth aren't fitting together correctly. So that can be a big issue for people. You can end up causing you to drool a lot at night, or cause movement of your teeth or teeth pain. That's why fewer than 50% of people actually wear their appliance consistently. So if you're not wearing it, it's definitely not working. So, and over time, a lot of people don't have issues at the beginning, but then it becomes an issue later on after they've been wearing it for a while. So it's something to keep an eye on. Okay. And it's often not covered by insurance. It can be thousands of dollars. So that can be a prohibitive factor for people as well. All right, let's talk about CPAP and BiPAP. This is the gold standard treatment for sleep apnea. If you are able to tolerate it, it does tend to successfully treat the sleep apnea. The problem is a lot of people don't tolerate it well. This is an example of a full face mask, which covers the nose and the mouth. There are two different ways to deliver the air pressure. One is CPAP, which is continuous positive airway pressure, and one is BiPAP, or bi-level positive airway pressure. The CPAP is just a constant pressure of air, and that's true whether you're breathing in or breathing out. And that works as what we call a pneumatic splint, to hold things open while you're sleeping so things don't collapse. So that air pressure, it creates this air pressure that holds the airway open. Yeah, and you can see here talking about pneumatic splint, and you're creating that seal around the nose and mouth. Sometimes it just goes around the nose, and it keeps things open. The BiPAP does a higher pressure while you're breathing in and a lower pressure while you're breathing out, but it still always gives you some sort of pressure. So yeah, the problem is a lot of people just don't tolerate it well. But it almost always resolves the sleep apnea if it's worn consistently and at appropriate pressures. But there's a lot of different numbers on this, but some say 68% are adherent at the 5-year mark. So we need other options for people who can't tolerate the CPAP or don't wear it, because it's really important to treat the sleep apnea. So we're moving on to surgical options, which we'll be talking about for the remainder of the talk. Let's start with nasal surgery. So nasal surgery can often improve the ability to wear a mask, because if people don't have good airflow through the nose, it can be hard to tolerate those masks. And it can improve snoring for people who don't have sleep apnea, but it does not typically cure obstructive sleep apnea. So don't let somebody convince you that if they straighten your deviated septum, that your severe sleep apnea is going to be resolved, because that's not typically a problem with the nose. It's a problem further back and a problem with the throat. But we do often use nasal surgery as an adjunct, and it can, like I said, often make it easier to wear the CPAP. So it can be an important component. Okay, and then there are surgeries that are focused on removing tissue. So tissue that is obstructing. So we're going to start by talking about tonsillectomy and uvulopalatal pharyngoplasty, or what we call UPPP. So I mentioned this before, but the tonsils can cause obstruction, particularly if they're large. And so we oftentimes remove those. You can see the pictures pointing to the uvula, where the uvula and tonsils are here. And then we can do other surgery on the soft palate, the uvula, that area of the back of the throat. And that, there are different ways to do it. You can see there's 3 different examples there of what it might look like at the end of the surgery. Sometimes your uvula is gone, sometimes it's still there, but smaller, and there's some stitches and things. You can see the last one circled there. I typically do that version where you still leave some uvula intact and you resuspend some of the muscles in a different direction. Tends to be more effective than the old versions where things were just kind of chopped off and removed and have fewer side effects. But it is a difficult procedure to recover from. It is really painful and it really lasts for a good 2 to 3 weeks, and things just don't feel normal even for longer than that. So the older techniques, which I referred to, have more about a 68% success rate, and the newer techniques are higher. I just want to put success in quotes here with a grain of salt. Success does not necessarily mean you have zero sleep apnea. It oftentimes means there is a significant reduction, but you might still not be in the normal range. And different studies define this differently. So it's a little hard to compare. Sometimes you're comparing apples to oranges when you're comparing different studies, but in general, the newer techniques are more successful, and it tends to be more successful if you're really choosing patients who are a good candidate based on their anatomy. But it can be really helpful, but it is definitely one of the tougher surgeries to recover from. Okay, another surgery where you're removing tissue is called a tongue base resection. And you can see the back of the tongue can sometimes be large or big or inflamed. And so you can remove the tonsil tissue that's on the back of the tongue, called a lingual tonsillectomy, or remove part of the tongue muscle itself. This is, again, a painful surgery and can cause some swallowing issues, at least initially, but can be a helpful adjunct. And the success rates really vary depending on the patient and who you're choosing to do this on. Okay, so this is, I think, one of the most exciting new developments in treatment for obstructive sleep apnea surgically. We're going to talk about the upper airway stimulation device called the Inspire implant. So this is a nerve stimulator implant that we use to treat obstructive sleep apnea. It's nice because it is working with your own anatomy and the function of the nerves and muscles without removing any tissue. Nothing you're doing is irreversible. It's not removing parts of your palate or your tongue or anything like that. And it tends to be a lot less painful and easier to recover from and more effective. It's for patients who have moderate to severe obstructive sleep apnea. You can't be too overweight. It's not approved for patients typically with a BMI over 32, sometimes as high as 34. And you have to pass an airway exam. Don't advance the slide just yet. I want to talk a little bit about what the device looks like here. So all of this is implanted underneath the skin. Nothing's on the outside except for the remote control that you use to hover over the device, and that's what you turn on and off. So what happens is when you're sleeping at night, when the device senses with this breathing sensor that you're breathing in, it gives a little impulse to the nerve here, and that causes your tongue to stiffen and move forward slightly. We talked a lot about how the tongue falling back can cause an obstruction. So this is moving the tongue forward and out of the way. Also, it stimulates other muscles in the airway to also to open the airway in that way. So with each breath, it's activating these muscles and opening the airway. It doesn't wait for you to have an obstruction or a collapse. It's doing this proactively with each breath. So you can feel it. You can feel your tongue moving in and out, and it's something people have to get used to, but it can be really effective, and you're not wearing anything on your face, nothing in your mouth, so you don't have that the mask that you're struggling with at night. This is kind of what the size of the device looks like. It does have a battery life of about 11 years. So after 11 years, that portion of the device has to be swapped out for a new one. There are some restrictions on MRI scans. You can still get MRIs of your head, neck, arms, and legs, but you cannot get MRIs of your core body or your spine. And some imaging centers will still perform those types of MRIs by just changing some settings on the MRI scanner, but it is technically off-labeled and not considered allowed. Okay, so what's nice is there's no resection of tissue, which I mentioned before. It's very portable. All you're bringing with you if you're traveling is that little remote control. You're not bringing a whole, machine with tubing and mask and all that sort of thing. So there's a lot of lifestyle benefits over CPAP. It is over 80% effective, so it's not as good as CPAP. It's not 100% effective, but most patients get really good benefit from it and continue to get benefit at the 5-year mark and tend to tolerate it well. But I will say this is a device that's only approved for people who cannot tolerate CPAP. So it's not something that we're choosing just out of convenience. We still try CPAP first and really try to get that to work for patients. If it doesn't work, then we have this as an option. Okay, and then we're going to briefly mention a couple more here. Jaw surgery or maxillomandibular advancement. This is a surgery done by oral surgeons, not by myself or ENTs typically. And you're actually breaking the jaw in multiple places and moving the jaw forward. And this can be done of your lower jaw, your upper jaw, or both. And as you can imagine, it's fairly painful and there's a lot of swelling and recovery afterwards. It can also change the look of your face. So here's another picture. You can see those plates and screws securing the jaw in a new position. But yeah, it changes. It can often change how your face looks because part of your jaw, either upper or lower, is moving, and you have to make sure your teeth are fitting together well and all that sort of thing. So it's a pretty big surgery, tough recovery. Your jaw is usually wired shut for at least 6 weeks or so. There's a lot of swelling. You're on a soft diet, things like that. But it can be really effective in the right patient and can be a lifesaver. So good to know about. Okay, finally, tracheostomy. Now, you might think it's silly to mention this one, but I want to be complete here. So tracheostomy is a tube that goes through your neck into your trachea or your airway. So you do not have to be connected to a ventilator. It's just open to the air. And this will cure sleep apnea in 100% of patients. So in some really severe cases, particularly if people are really massively overweight and are running out of other options, we can do this and it will cure your sleep apnea. Now, obviously, it's fairly aggressive and life-changing to have a tracheostomy, but it can also be life-saving. So it's just something to note. Okay, so conclusions of the talk today. Obstructive sleep apnea is a widespread problem. It has severe health and quality of life consequences, so it's very important to treat. CPAP is the traditional therapy, which is very effective if you can use it. Other therapies exist. They have a big range of invasiveness, side effects, complications, effectiveness, and cost. And it's important to speak with your sleep doctor about what might be best for you, your friends, and family. Like I said, I focus on sleep surgery, so people end up talking to me typically if they can always be just if they're worried they might have sleep apnea. We can always order a sleep study and help do the workup. And then also, if they're having trouble with the CPAP and need other options, they see me and we can work through what some of those surgical options are. Okay. And I will answer some questions. I'm going to check the questions here in a second, but I just want to mention I have 3 offices, Newport, Irvine, and Seal Beach. And I'm at different offices, different days of the week, but you're welcome to give the office a call if you want to consult and speak with me and go over any of the things we talked about today. Okay. All right, I'm going to check our questions here. I think some people wrote in. So somebody said, I've heard that Inspire works about 70% of the time. Is that correct? What are the indicators of the likely success? So yeah, 70 to 80% is usually what people quote right in there. So that is fairly accurate. You know, the things that we make sure before we do an Inspire implant is that you're an appropriate weight and that you're not too overweight, that your sleep study has the right parameters, moderate to severe, and we look at a couple other things on the sleep study. And then I do an airway exam, which is a sleep endoscopy. And that is when I bring you to the operating room, make you sleepy with some medications, and put a scope in the nose and watch how are things collapsing when you sleep. So I watch the collapse and make sure you're a good candidate for Inspire from that standpoint. And that's how we determine if you're a good candidate. Now, we can do everything possible to make sure you're a good candidate, and sometimes you're still one of those people who it doesn't work well for. But that's how we narrow it down. All right, somebody else is asking about what are the complications of an Inspire implant. So, with any surgery, you can get bleeding, infection, pain around the implant, scars. There are 2 incisions to place the implant, one in your neck, one over the device. Infections when you have an implant are even more serious and sometimes require removing the device to get the infections to clear. Sometimes the device can malfunction. It cannot be working correctly, and parts of it may need to be replaced. That's always a possibility with a device. And then the nerve that I'm dissecting out in the neck, there is a chance of causing weakness to that nerve or weakness to part of your tongue, but that's a pretty unusual complication, and it's almost always temporary when it happens. So I think in general, it's a pretty safe surgery and really tolerated quite well. So somebody was also wondering, could Inspire be used for people who have neurologic problems like muscular dystrophy? So we have not done great studies on this yet. Inspire is relatively new. It was FDA approved in 2014. So there aren't studies that show us whether it works for muscular dystrophy, but I think that there's good reason to believe it would work well, and can have a discussion with me and the patient about risks and benefits and things like that. But it could be worth trying in somebody who has muscular dystrophy, particularly if they've exhausted their other options. Okay. So somebody else asking more about Down syndrome and what options Down syndrome patients have, because a lot of them have particular trouble tolerating the CPAP. So a lot of Down syndrome patients, their sleep apnea presents when they're a child, and they end up getting their tonsils and adenoids removed and some of the other surgeries we discussed. But also recently, the Inspire device has been approved for Down syndrome patients, and even some Down syndrome children. So that is really exciting. I think it's a really nice option. They don't have to wear anything on their mouth or their face, so it can often be tolerated a lot better. So there have been some really good studies on Down syndrome and the Inspire device. So somebody else was wanting to know, how does your weight and your neck circumference actually affect the airflow through your throat? So when you have a bigger neck and you're more overweight, that can put more pressure on things to collapse. So the walls of your throat around your tongue are more likely to collapse because they have more weight and pressure around them. Also, sometimes it'll end up meaning that your tongue gets bigger. You have some more fat in your tongue than other people, and a bigger tongue, crowding, tongue falls back and things like that. So it's all about pressure and narrowing and collapse. Okay, all right, lots of questions. This is good. All right, can you have the Inspire device with a pacemaker? Yes, you can. You can have both. We tend to implant the Inspire on the opposite side as the pacemaker, and the Inspire can go on either side. But yes, there is no reason why you cannot have both. They do not seem to interact. How do you define intolerance to CPAP? It's a great question. You can define it a lot of different ways. But in my mind, if for whatever reason you're not wearing your CPAP, and that might mean that you absolutely refuse to wear it because you feel claustrophobic. That might mean you try to wear it, but it ends up on the side of the pillow every night and you don't know why. But if for whatever reason you're not able to wear your CPAP for most of the night, for most nights, then I think that we consider that intolerant. So that's true when we're looking at people for the Inspire device too. We just have to show that they're, explain exactly why and how they are not able to use their CPAP regularly. Oh, somebody was asking about whether the Inspire device is paid for by insurance. Good question. I usually mention that I did not. It is paid for by insurance. It is paid for by Medicare. We used to have some difficulty getting it approved, but it's become more and more common. So most insurance plans have set policies. So as long as we meet all the criteria on the policy, it should be paid for, no problem. So you'd be responsible for copays and deductibles like any other surgery. But typically we can get it paid for. The device itself is expensive. It's about $24,000. So it would be very difficult for most patients to pay that out of pocket. So that is something that insurance covers. Okay. All right, so somebody said that her husband is gasping when he sleeps at night. He feels that he's doing fine. The sleep study showed mild sleep apnea. Any suggestions? So this is a case where you might focus more on those lifestyle changes, where if you make little improvements in different ways, it might be enough that you get him to the normal range or close to the normal range. So that would be things like weight loss and exercise, and then positioning in the bed. So trying to sleep on your side more, sleeping with the head elevated. Little changes like that when you just have mild sleep apnea are sometimes enough. And then I will say there are some devices that, like a band you can wear around your chest while you're sleeping that cause you a little vibration every time you roll to your back. And that encourages patients to stay on their side. There's a lot of evidence to show it's not actually waking you up completely, but it's disturbing you just enough so you roll over. So things like that, these positional sleep apnea devices can sometimes be helpful. The sleep study will often show what are your numbers on your side versus your back, assuming you spent some time in each position during the study. And that can be really helpful so we know, oh, if you're on your side all night, you actually are in the normal range. Excuse me. Okay. All right, so what should you do if you're worried you have obstructive sleep apnea? So really, you can start in a lot of different places. You can start at your primary care doctor's office. You can start at my office. You can start at a pulmonologist or neurologist's office who has some sort of specialty or interest in sleep. So any of those people can start you on the path. Really, what you need first is a sleep study. So yeah, you can start in any of those spots first. Okay. All right, I think that's about it for our questions. I appreciate everybody participating today, coming and asking questions. I hope it was helpful. I believe this is recorded, so hopefully it will be available to people later. I'm not sure about the slides, but we'll get that information to everybody. But thank you again so much, and hope to see you all soon.